Now we will have the welcome address by me. Myself, the AMS, the chairman of the Organ Donation Committee. I welcome you all for this program. I like to welcome our President, Dr. P. Seguttuvan sir, for this meeting. In his busy schedule, he is able to attend this meeting. And Dr. K.M. Abul Hassan sir, the immediate past president for this meeting. I welcome Dr. Karthik Prabhu, our honorary state secretary, and Dr. Sridhar, the president-elect 2025, and Dr. Gauri Shankar, the state finance secretary, and Dr. the other vice presidents and other dignitaries. First of all, I like to welcome our moderator of the day, Dr. Arun Sheshachalam, and the speakers of the day, Dr. Sakti Sivakumar on kidney donation, Dr. V.R. Ravi on stem cell donation, and Dr. Sibu Varki on eye donation, and Dr. S. Prabhakaran on blood donation. I welcome you all for this. Now I invite our president, Dr. Seguttuvan sir, to give his presidential address.
Thank you, Rajesh. Respected immediate past President Dr. Abul Hassan, respected President-elect Dr. Sridhar, respected Honorary Secretary Karthik Prabhu, Finance Secretary Dr. Gauri Shankar, Chairman of the Organ Donation Dr. Rajesh Babu, Advisor for the Blood and Organ Donation Deputy Dr. Sukumar, and Convener Dr. Suguna, Dr. Rashmi, and the speakers Dr. Shakti, Dr. Ravi, Dr. Chibi, Dr. Prabhakaran, the moderator Arun Sheshachalam, to all the delegates who are attending this organ donation meeting. Good evening to everybody. Dr. Rajesh Babu is doing a wonderful job this organ donation meeting. Along with his Academy of Medical Specialties also, he is doing great work. Commendable and has to be appreciated. Every meeting he is introducing any new things and recording the latest events. That is the overall waiting for the kidney transplantation. Everything he is giving in the particulars. And I also asked the presidents and secretaries of the various branches to look into it, allot for 5 minutes for your CME program. Ask the speaker to have the blood donation, organ donation, everything. Inform all the delegates, inform all your members so that it can be spread and it can be voluntarily, can be give, they can donate their organs. With these few words, thank you for giving me the opportunity, Dr. Rajesh Babu. Over to Rajesh Babu.
We invite our immediate past president, Dr. K.M. Abul Hassan sir, to give his felicitations.
Thank you, Dr. Rajesh. Respected President Dr. Seguttuvan, and all the speakers of today's webinar, and all the office bearers, including Dr. Sukumar, Dr. Rashmi, and Dr. Suguna, speakers Dr. Sakti, Sibu, Dr. Ravi, and Dr. Prabharan, moderator Arun Sheshachalam, and all the delegates. I am very happy in two accounts. Number one is this particular topic of organ donation is very much discussed, sensitized, and maybe is one of the priority topic today because of the organ donation committee. This particular subject is very much very popular in Tamil Nadu state compared to the rest of the country. And I am a Tamil Nadu state is very happy about it. And so we thank Dr. Rajesh Babu, who had done a wonderful job last year also in the same field, and this year also. And the second thing is, our organ donation committee has also started its activity in the colleges last year, and this year also I think Rajesh will be having plan to do this because this is very important milestone development in allopathy. that is organ transplantation and also organ donation. So I think it is a duty of doctors, and particularly the organization of the doctors, Indian Medical Association, should give topmost priority for this topic and take it to the deep into the public and also particularly youngsters, so that they realize the importance of giving organs. We all heard that the fertility rate is coming down in our India. The population also will go down in the maybe 1 or 2 decades time. So I think the demand for organs will be huge, and we have the potential to meet the demand. But for that to happen, we need to sensitize people, particularly youngsters. So I will be doubly happy this year also. Rajesh conducts a program, sensitive program in the colleges, so that the youngsters will become organ donors. So the large number of organ donors will be registered and be there ready for kind of demand. The demand is also increasing. You see that 700,000 people are registered for kidneys. So I think this particular movement by IMA will travel in the direction of meeting this objective and also demand. Thank you very much, Dr. Rajesh, for this wonderful opportunity, and thank all the speakers for sharing their valuable time for this particular event. Thank you.
Now we invite our State President-elect Dr. Sridhar sir for the meeting. I think sir is not joined, I think. Now I invite Dr. Karthik Prabhu sir, our Secretary of IMA TNSP.
Thank you, Rajesh Babu sir. Most respected President Singleton sir, President-elect, President Immediate Past President Abul sir, and all leaders here. Rajesh Babu sir, you're doing a wonderful job. I'm in between a minimum wages meeting. So best wishes for this program, sir. I'm sure since the last blood and organ has been mixed, your activity is also doubled and elaborate programs you're doing. Best wishes to one and all, and I congratulate all the speakers and my good friend moderator, everybody, sir. Thank you.
Thank you, sir. Now I invite Dr. Gauri Shankar sir, our Honorary State Finance Secretary, to give his address. Felicitation. Okay. Now I invite Dr. Ravi sir to conduct today's CME program. Sir, unmute, blindly unmute yourself. Sir, unmute.
Thank you. Yes, sir. Thank you. Thank you, Dr. Rajesh Babu sir, for the introduction. So all of us know and should know that already Tamil Nadu tops the list in organ donation throughout the country. And it is no surprise that people are calling Dr. Rajesh Babu from other states to know why and how Tamil Nadu is topping the list. And as Dr. Abul Hassan sir rightly mentioned, that the future, the demand will be more. So today we included the topic of stem cells only to address this future, because the Dr. Shibu Varki's talk about eye donation, they have done a lot of work on limbal stem cell therapy, which has considerably reduced the demand for the cornea. So by using the stem cells, we can reduce the demand for the particular organ. So that is going to be the future. So even when the demand is more, if we are up to the mark, if we are in the forefront of research, we can definitely meet the demand. So today when Dr. Rajesh Babu asked me to coordinate this meeting from the Trichy IMA, naturally my first thought was about Dr. Arun Seshachalam, because he's a very dynamic person. He is the current secretary of IMA Trichy. He's going to moderate this session. He is a famous pediatric and medical oncologist, and he is the current IMA secretary of Trichy. He is the clinical head of the GVN Cancer Institute, one of the oldest institutes in Tamil Nadu, and he is a managing trustee for KK Charitable Trust. And interesting thing is, he is a project director for rehabilitation on wheels. It is actually end of the life care at home delivered to the patients who are suffering from cancer. So he is a very dynamic personality. He has got multiple facets. He's a teacher. He's an associate professor of pediatrics in Dhanalakshmi Srinivasan Medical College. He's a researcher. He's an author of several publications, and he is a principal investigator in several trials. Not only that, he is also a management graduate. He is an MBA in healthcare management. So I thought with Dr. Arun Seshachalam, we can conduct this program on blood and organ donation, and all the other speakers who have joined me today will definitely help in showing the light on the organ donation and blood donation. Now I request Dr. Arun Seshachalam to introduce the speakers and continue with the session.
Thank you, Ravi sir. It's so kind of you. So it's a wonderful meeting. It's a need actually, so because most of like as a medical on. But if you ask me valuable information, no other specialties, and so that first we should be aware so that we can educate others so that this particular topic or this particular awareness is, I think there are 4
Breaking.
topics. Yeah, it's breaking. Okay.
Yes.
Okay, fine. I'll just with this, I'll just try to change the internet connection. To start with, we'll go for the kidney donation, which will be by Dr. Shakti Selvakumar. He is MBBS, MD, DNB in nephrology. He did his DNB in nephrology in KG Institute of Nephrology in Coimbatore, and he did his MD in Balaji Medical College in Chennai. And he has completed nearly 125 transplant after completing his DNP in nephrology. And he has published plenty of articles and research papers. And with this, we'll start the first session by Dr. Shakti Selvakumar on kidney donation. Over to Dr. Shakti Selvakumar. Dr. Shakti?
Yes, sir. Good afternoon, sir.
Yeah.
Yes, sir. Sincere thanks to IMA and the distinguished leaders of TNSB for this opportunity. Can I share my slides, sir?
Yes, you can.
Can everyone see my slides?
Yes, sir. Yes, visible.
Yes, sir. So this will be the overview to talk. Why should we support organ donation? And who can be a living donor? And what are the criteria to define a deceased donor? And what are the steps to improve organ donation? So we all know that organ failure is a critical stage, and it has a lot of demerits, and the quality of life of a patient who is having organ failure, especially renal failure, can be very poor, and the life can be uncertain for these patients. The patients who are on dialysis can even die due to a simple human clerical error of mixing chemical solutions. And every time a patient who is put on dialysis, the 4 hours whenever they have been undergoing the treatment, they're at very severe risk of cardiac failure or sudden cardiac death. So the life-saving solution for these patients would be organ transplantation. If you look at the graph, this study done by AIMS, Delhi, and the survival rates of a patient on dialysis and transplant are compared here. If you look at them, the life of transplant patient, it improves post-transplant, but dialysis patient usually have a decline in their quality of life, and they might suffer a premature death even in younger patients. If you look at the cost, people might think transplantation costs more than dialysis. It might be true initially, but as the year progresses, the cost of dialysis is actually 2 to 3 times comparatively more than that of transplant. This was a study done by US UNOS, which shows that as the time progresses, dialysis cost actually is 2 to 3 times more than transplant. So it might look costly initially. In the long term, transplant is actually cost saving. This is how a renal transplant recipient would be having his kidney immediate post-transplant. It would be pinkish after arterial anastomosis and venous anastomosis. And the one where the surgeon is holding is the ureter. So what are the categories of donors? Living and deceased. So who can be a living donor? A competent adult possessing a decision-making capability, willing to donate, free from coercion, medically and psychosocially suitable, and who can understand the fully informed risks of and benefits of donation, and who also can understand the alternative treatments available to the recipient. Age should be 18 to 70 years, BMI should be less than 35. The donor should not have any cancer or active infection, and they should have an adequate renal function, and ABO compatibility is also consideration but not a contraindication. So this is the usual protocol which will follow. A donor, after social, economic and psychiatric evaluation, would undergo medical evaluation. We will screen them for the renal function, cardiovascular diseases, infectious diseases, malignancies, and then we look at the matching, and then once they accept the risks, we proceed with surgical evaluation. So what are the contraindications for any living renal donation? Evidence of renal disease, significant renal urologic abnormalities, infectious disease, especially HIV, HPSAG and HCV is now becoming relative contraindications, active malignancy, chronic illnesses, poorly controlled psychiatric illness, cognitive deficit, current pregnancy, hypertension, diabetes mellitus was a past contraindication, now it's becoming a relative contraindication, recurrent renal stones or bilateral stones, history of thrombotic disorders with risk of future events. So what are the assessment goals of a living donor recipient? Is the donor sufficiently healthy to undergo a surgical procedure? Do they have a normal kidney function with minimal risk of future kidney disease? So any medical condition that can be causing a high risk of future renal failure is a contraindication. And the donor should not process any risk to the recipient in terms of communicable disease or malignancy. So the donor should undergo a full psychosocial evaluation. They should understand the informed consent and the risks of undergoing the procedure. And the psychiatrist who is evaluating the donor should understand donor's motivation, and they should always exclude the coercion, and they should always rule out psychiatric problems that would impact the decision-making process. Psychiatric illness is always a contraindication for renal transplantation. And we'll also look at the cardiac evaluation, direct cardiomyopathy, coronary artery disease, compensated cardiac failure, and arrhythmias, and significant valvular disease is a contraindication. Diabetes is now becoming a relative contraindication. And we'll also look at the immunological evaluation, cross-matching, and HL tissue typing is essential. ABO incompatible transplants are being increasingly now done nowadays as donor scarcity increases. So what do you do if we have more than one donor? So we'll usually match a single donor depending on the HLA match donor age. And we'll usually go for biologically donors than unrelated donors like spousal. And when more than one family member is available, we should commence the evaluation of the best match relative. And once if there is any problem, then we go to the next. Parallel evaluation is not advised. And if donors have similar matching rate, that means a sibling or matched parent, we'll always choose the older donor because it might look a bit difficult, but if the present donor's kidney fails in the future, the younger donor can always be a second donor for second transplant. We always try to avoid communicable diseases, fully treated HBV, HCV, syphilis, tuberculosis, latent CME do not preclude donation. But in these diseases, recipient should receive prophylaxis. HIV is not a contraindication. So what about malignancy? Melanoma, renal cell carcinoma, any urologic malignancy, choriocarcinoma, hematologic malignancy, gastric cancer, lung cancer, breast cancer, Kaposi sarcoma, and monoclonal gammopathy as contraindication. But donation can be acceptable for in situ squamous cell carcinoma, a cervical carcinoma if deemed cure and the potential of transmission has been excluded. There is no evidence that women of childbearing age has a deleterious effect on fertility, and there are studies to show that donors can become pregnant and there is no risk of any hypertension or miscarriage in the future. But usually we'll advise to delay the pregnancy for at least 6 months to allow for the maximum compensated hypertrophy of the kidney. Whatever incidentalomas in the adenoid nodules, usually if they meet a criteria of benign adenoma and functional workup is negative, then we proceed with renal donation. 30% of renal lesions could be low density and that might not preclude the donation. But larger complexes always need evaluation. The non-related donors is a bit of a slippery slope. These people are those who come forward to donate a kidney to someone who is unknown to them. We call them altruistic donor or good Samaritan donors. They can play a critical role in exchange programs, but most of them say they are emotional related. There is a risk of organ trade. So we need to have a clear documentation and we have to undergo all the documented crucial procedures to rule out any risk of slippery slopes and organ trades. There are concepts of living pair donors when one donor is unsuitable for the recipient. So there can be paired exchanges. It can be 2-way, 3-way, and recently Gujarat hospitals have done up to 10-way transplants. There is another school of thought where people think that it is unethical to mutilate a living donor for organ donation. So the concept of cadaver came into the picture. The TNOS or Transplant is the present government body which is allocating the kidney for the recipients based on the donor evaluation. So we all know about brain death, a stage where all functions of the brainstem have been permanently and reversibly ceased with irreversible loss of consciousness, no brainstem reflexes, and the patient cannot breathe independently. The certification under my panel of 4 doctors and 2 sets of apnea to be carried out minimum 6 hours between the tests. There are 2 categories: standard criteria, extended criteria, and donation after cardiac death. The third criteria, donation of cardiac death, is not being done in India except for one of few centers near Delhi. Predominantly Tamil Nadu, what we follow is standard criteria donor and ECD extended criteria donor. What is standard criteria donor? The donor should be having an age of less than 50 years, suffered brain death, ideal traumatic cause, no hypertension, presumably no diabetes. Diabetic is becoming a relative contraindication nowadays. An expanded criteria donor as ECD is when we select a donor with a marginal kidney, defined as a deceased donor who is more than 60 years or age 50 to 59 with 2 additional factors, either hypertension, death due to CVA, or increased creatinine at the time of death. So RT is the leading cause of death in India. If you look at the statistics, this was last year's statistics. India stands third next to USA and China. If you look at the staggering difference, the number of transplants in India is predominantly living compared to deceased in USA and China. This is predominantly due to the following reasons: unawareness between the government and private sectors. If you look at the statistics over the past 10 years, the number of patients who are awaiting transplants is around 1 lakh. But the number of patients who underwent transplant is only 11,000 who are living and only 5,000 deceased. This is the last year statistics. Fatal RTA in Tamil Nadu is around 15,000. But if you look at the active waiting list, this was done 1 week back. It was around 6,100 for kidney, and liver is 400, heart is 29, and so on and so forth. But people who donate is less than 10%, and that is the real sad truth. So only 10% of these people, let's say around 600 people, get active kidney transplant every year. The supply demand difference is hugely staggering. So what are the issues? There is no funding for the program from government. There is no efforts on the hospital side, either be private or public, to identify and maintain donors. And there is no awareness of brain death concept across the community. So cadaver transplant is essentially a social function. We have to encourage people so that around 95% of them who have the families of brain dead come forward for the donation. We have to project the positive aspects of donor to the general population, religious heads and leaders and healthcare workers, and through the mass media. Studies show that blood donors have better knowledge of organ donation. So whenever someone becomes a blood donor, we should advocate about organ donation to them. They can spread this information to their relatives and so on and so forth. There's a concept of presumed organ consent, which is very famously started in Spain. Belgium, Austria, Finland, France, and Norway and Singapore have implemented this. France's presumed consent law has increased organ donation up to 5,000%. Belgium has seen an 183% increase in organ donation. Austria has passed this law in 1982. By 1990, almost all the patients who registered for cadaver used to get the kidney. Presumed consent is a concept where whenever someone becomes brain dead, it is presumed that they have given consent for organ donation, and only when the family doesn't want to be donating the organ, they will decline. But in India at present, there is no presumed consent. Now the hospital coordinators or the hospital doctors have to ask for the organ donation, and only if they are agreeing, then the donation proceeds. So what are the parts which can improve in the hospital side? Qualified incentive units within ICU and retrieval teams could be prepared and ready. Packing organ transplantation should be properly done, and more supportive organization, not only Transplant, and we also can participate. And the transplant coordinators can be very well trained in HLA tissue typing and cross-match facilities, which should be improved all over Tamil Nadu. So if the current rate of organ donation in India is around 0.05%, this is donors. If it increases to 1, we can have 1,100 organ donors, 2,200 kidneys, and as it increases to 3, 10, and 20 per million donation rate, around 44,000 kidneys can be transplanted from deceased donor itself. This would bridge the gap between the supply and demand. This is an initiative by our own Kaveri hospitals, Kodai, which is Kaveri Organ Donation Awareness Initiative. I spearheaded this program over the past 6 months. We collect donor pledges for all the patients and attenders who visit our hospital. Around 4,000 people have registered so far, and we are planning to continue this for the next month's kidney donation day. Thank you.
Thank you. Thank you, Shakti. It was very lucid presentation. You made it very crisp, and what is needed for us, you nicely summarized. Any questions to Dr. Shakti?
I have questions at the end of the session, sir. Because
Okay.
all the things joined together only we can have it, sir.
We can have. Then that is fantastic.
Sir, we will go to next.
Okay, we'll go to the next talk. It will be by Dr. Shibu Varghese. He's well known actually in Trichy. Everybody knows him. He's very famous here. He has done more than 1 lakh eye surgeries. He's the director of Max Vision, and he will be speaking to us on eye donation. So let's hear from the best in the field. Over to Dr. Shibu Varghese.
Hello, everybody. I hope the screen is visible.
Yes, doctor. Yes, doctor.
Yes,
It's
sir.
very well.
Yes.
Respected President, President-elect, past President, Secretary, Finance Secretary, and Chairman of the Organ Donation Committee of IMA Tamil Nadu, and my dear friend, Dr. Ravi from Trichy, and Dr. Arun, and the other speakers on this forum. And all of you, a warm welcome to this talk on eye donation. Presently, I am joined this meeting from the town of Kumbakonam, where I visit every Friday. And why I want to mention about Kumbakonam, this is the city where late Dr. Ravi, ENT surgeon, who was one of the most outstanding eye donation motivators in his lifetime. He has collected and transmitted humongous numbers of corneas and eyeballs in and around this area. I pay homage to him as I start my talk. The eyeball is traditionally, for our easy understanding, divided into an anterior segment and a posterior segment. The important structures of the posterior segment, optic nerve, retina, whereas the anterior segment, cornea and the lens, of which cornea accounts for the major refraction of the eye. Nearly 40 to 50% of the refraction happens from the cornea. Corneal blindness is blindness due to scarring or opacification of the cornea due to any cause. And based on the density of the opacity, it is classified as leukomatous opacities, macular opacities, or nebulous opacities, whether all the layers of cornea are opacified or only few. Corneal blindness has staggering numbers in India and the world. India is taking the third leading cause of blindness, whereas fifth worldwide. Of the 45 million blind people in the world, 6 to 8 million are corneal blind people. Thailand has the highest at 19.9%. India is second at 15.8%. Sri Lanka has the lowest at 1.5%. India has about 1.2 million affected people, with about 25,000 to 30,000 people being added every year. The highest prevalence of corneal blindness was found in a study in UP in Bijnor at 3.7% and lowest in Kerala at 1.1%. The causes for corneal opacification and blindness, the leading causes, corneal infections like keratitis, bacterial, fungal, viral, and also the traditional medicine and herbal application. In some areas like sub-Saharan Africa and Central Australia, trachoma leads the cause, whereas corneal trauma, including chemical injuries, and in some places, pseudophakic bullous keratopathy as a result of bad cataract surgery, keratoconus, and corneal dystrophies. What is the impact of corneal blindness? One, direct cause, that is medical expenses of the patient. Indirect causes like loss of productivity of the patient and also the caregiver is an additional burden. And when children are involved, it also has an educational impact to the children. There is strain on the healthcare system, especially in lower and middle income countries where prevalence is high, and government may need to allocate special resources for social service and disability management. So globally, it's mostly the low and middle income countries which are affected, because these are the countries where, one, the prevalence of corneal blindness is higher, and also access to healthcare is lesser. The challenges we face in the area of eye donation, one is lack of awareness. People are not aware about the amplitude of the problem and the need of eye donation, and also sometimes the process that is involved. There are a lot of misconceptions and myths, like about disfigurement and about life after death. There are also cultural and religious beliefs. In a particular study, this was found to be 80% of the reason of refusal to eye donate was about cultural and religious beliefs. Sometimes inadequate infrastructure, like inadequate eye banks or lack of trained personnel and professionals. Low donation rates, in spite of a lot of motivation, the number of people who pledge the eyes are less. And even if people have prior consent, at the time of death, they may not be, the relatives may not donate. Then, of course, legal and procedural hurdles. And eye donation is a time-sensitive procedure. Corneas must be harvested within 6 to 8 hours of death, which sometimes in inaccessible areas may be difficult. There could also be delays in communication and transportation. As I said earlier, lack of awareness among healthcare providers. And also sometimes lack of proper coordination between governmental agencies, NGOs, eye banks, and inadequate follow-up can also be the cause. The Eye Bank Association of India has tried several mitigation strategies, even as our own chairman of the committee, Dr. Rajesh Babu, was previously telling us a lot of.
To Dr. Shakti. So by that time, I think Dr. Shubhu Varghese should be able to join.
Please talk with the Shubhu Varghese, sir.
So any questions to Dr. Shakti, nephrologist, who was presented on kidney donation as his first presentation? Any questions to Dr. Shakti?
Is he there, sir?
Yes, ma'am. Yes, ma'am. I'm there.
Sir, do we have to routinely do angiogram before transplant for the recipient?
Ma'am, coronary angiogram, ma'am.
Yes, ma'am. Yes, sir. Yes, sir.
Coronary angiogram, it's a coronary, ma'am. Usually, for diabetic patients, recipients who are more than 60 years, usually prefer an angio. If TMT for younger recipients, usually TMT is adequate. And if there is any questionable result in TMT, or if there is any unusual arrhythmias, we usually proceed CAG. For diabetic patients, the dictum usually is to follow CAG.
CAG, yes, yes. Thank you, sir.
Any other questions to Dr. Shakti? Okay, Dr. Shakti, this is Dr. Arun Seshachalam here.
Yes, sir.
See, it was very nice talk. Thank you. It was nice to listen to your talk. I just want to know, initially you said all malignancy are a contraindication for donation. After that, you said, carcinoma cervix is exempted, squamous cell carcinoma of skin was exempted. Can you clarify more on this? Because more and more cancer is getting cured and more survivors are coming, and they would like to donate. So can you throw more light on that particular aspects?
Yes, sir. Usual active malignancy is contraindicated, sir. So for every malignancy, there's a criteria. So in situ carcinoma, such as squamous cell carcinoma or in situ cervical carcinoma, can proceed, sir. Stage 1. And especially cervical carcinoma, if deemed cure, we can take it as a relative contraindication. We decide on case-to-case basis. And for example, breast carcinoma in situ, we accept. And post mastectomy after 3 years we accept, and usually we'll do a PET scan before proceeding. The ultimate aim is to prevent the transmission of the malignant cells from donor to recipient. And renal seeding and secondary malignancy transfer is comparatively rare, yet we want to even exclude that criteria.
Okay, fine. The other question is, after live donor, somebody who was given the kidney, what are the long-term complications for them you expect?
So predominantly hypertension is what we'd expect. And diabetes is become a relative contraindication. Before diabetes is absolutely no for renal donation, but nowadays early diabetics who are comparatively on the older side, let's say around 50, and diabetes recently indicated, and patient is on only one drug, presumably say metformin, and HbA1c is maintained less than 6. We select from case to case basis. Usually we try to avoid diabetics, but because everyone is diabetic at present, most of the donors were coming up. Familial donors are becoming diabetic or turned out to be diabetic. We are 4 sorts of the donors. So we screen them, and with stringent criteria and stringent donor follow, we do accept. So diabetes is not a contraindication, but hypertension, we expect complications. And when young females donate, we always anticipate complications of PIH. And other than that, so far patients who are developing renal insufficiency post donor is almost none. So hypertension is the only problem which we are worried about, and we always advise donors to be bit cautious during pregnancy.
Okay. Thank you, Dr. Shakti.
Yes.
I think some internet problem. Probably we'll go to the next talk. Dr. Ravi sir, you are there? Hello sir. Sorry, we lost you. Probably a bad internet connection.
From where I had dropped.
Yes, sir.
So, yeah, the eye harvesting is done by eye banks and by the hospital Cornea Retrieval program. Eye bank was started in India first by the Regional Institute of Ophthalmology by Professor Dr. R.E.S. Muthaiya. And the first legislation on eye banking and eye donation in 1957. The Eye Bank Association was formed in 1989. HOTA was brought into act in 1994. There is an important proposal for presumed consent for eye donation and cornea retrieval is under consideration by the government of India. In India, under the National Program of Control of Blindness, in 2004, a 3-tier system was established with 5 eye bank training centers, 45 eye banks, and 2,000 eye donation centers. This is the manpower. Different countries have different patterns. In countries like USA, United Kingdom, Australia, and Canada, we have a centralized eye bank. It's a national eye bank which collects and donates eyes to the corneas to the various surgeons. India has a hospital-based eye banks, whereas community-based eye banks are there in some other countries. The Hospital Corneal Retrieval Program, which was introduced in 1991, where a trained grief counselor is stationed at the hospital, and in cases of hospital deaths, the counselor approaches and counsels the next of kin. And this method has the advantage of knowing the donor's medical history, cause of death, and also identifying potential donors. And in a recent study, this has shown to have a higher yield than voluntary donors or post-mortem donors. The steps of eye donation include first an informed consent from relatives, which is presently mandatory, which may be done away with the Presumed Consent Act if it comes into play. And then the collection of blood samples of the deceased for HIV, hepatitis B, C, coronavirus, and also for syphilis. Absolute contraindications for harvesting are if the patient has an active viral hepatitis, HIV infection, viral encephalitis, any slow virus diseases, and rabies. So it could be either the whole eyeball that is enucleated or an in situ excision of a corneoscleral disc. In the eye bank, there is a preparation of the corneoscleral disc, which is to be done under a laminar flow hood. And then the cornea is evaluated and graded using a slit lamp biomicroscopy and specular microscopy. It is graded according to the quality of the cornea. And then, of course, next step is the storage and preservation, where the tissue has to be accurately numbered and labeled. And various mediums are available for short-term storage, Macquarie-Kaufman or MK medium, for medium range, Optisol, Cornisol, Usol, and long-term preservation can be done using organ culture medium or glycerol. Further processing, the cornea can be either dissected using manual or automated techniques to lamellar components, and the other parts like the whole globe, sclera, can also be preserved for various uses. Now coming to the actual numbers, India, the numbers per million is very low compared to the other parts of the world. India has about 3 to 4 donations per million population, whereas in other countries like US and Canada, it is in the range of 20 to 25. Coming to the corneal transplantation techniques, the full thickness corneal grafts or penetrating keratoplasty is something that is known, commonly known, where all the layers, all the 5 layers of the cornea are completely transplanted. But with recent advances and newer technologies, now lamellar grafts, where the specific diseased layers of the cornea can be transplanted, like a deep anterior lamellar keratoplasty, where only the anterior layers of the cornea are transplanted in patients in whom the endothelium is healthy, as in cases of keratoconus. And now we have also the decimet membrane endothelial keratoplasty, where only the deepest endothelial layer is transplanted in cases like endothelial dystrophies or bullous keratopathy, where rest of the cornea is normal and only the endothelium is diseased. So as I was saying, the deep anterior lamellar keratoplasty replaces only the anterior layers of the cornea. Endothelial keratoplasty, these techniques, they replace only the endothelial layer. And these lamellar keratoplasties lead to faster recovery and lesser complications and rejection rates as compared to full thickness or penetrating keratoplasty. Nowadays, we use minimally invasive technology like femtosecond laser assisted keratoplasty. In this, femtosecond laser is used to precisely cut both the recipient cornea and also the donor graft, so that you can create a exactly matching donor and recipient interface, so that the joining is very precise, and this gives a perfect fit of the graft with good visual outcomes. And also we have sutureless keratoplasty techniques, where the endothelial layer is placed without having to use any sutures, and it adheres by itself. And this reduces the post-operative astigmatism, giving much better visual recovery and also quicker healing. Other advances that we have in keratoplasty, one is the immunomodulation therapies that nowadays we use, the cyclosporin, tacrolimus, liftigrast. These have reduced the graft rejection rates. Use of anti-vascular endothelial growth factors like bevacizumab, which inhibits corneal neovascularization, which is a risk factor for rejection. Also, there is research going on for bioengineered corneal substitutes using collagen-based materials, and also to have decellularized donor corneas. This may become available soon. And as my friend Dr. Ravi sir was saying, stem cell therapy using the limbal stem cells in conjunction with keratoplasties or even without keratoplasties have come to have a big role in one, reducing the number of keratoplasties, and 2, in helping the grafts to survive without rejection, especially in cases like chemical injuries, Stevens-Johnson syndrome, and such kind of ocular surface disorders. Gene editing is another technology that is being explored, where the CRISPR is used to edit the genome, so that in conditions like corneal dystrophies, genetic conditions like corneal dystrophies, the chance of the cornea getting clear, or the graft not getting, or the dystrophies reoccurring in the graft can be prevented. Future trends, one, the big role of telemedicine, remote surgical training and consultations will help to serve the underserved areas. iBank innovations that improved logistics and preservation methods will increase the availability of donor corneas worldwide. 3D bioprinting of cornea is also an ongoing research, where corneas can be remotely 3D printed and can be available in distant places. Nanotechnology is also having a great role to play in future, where nanoparticle-based drug delivery systems are explored, which can help to improve the post-operative care and reduce complications like rejections. To sum up, India has significant share of global corneal blindness. The number of needed keratoplasties is 100,000 per year, for which around 200,000 corneas need to be harvested per year. The current number of keratoplasties being performed is approximately 55,000 keratoplasties per year. So you can see the huge gap between the need and the demand and the supply. Eye donation drives in the terms of motivation, commitment, and compliance of patients is something that has to be looked at. And, kudos to IMA, especially IMA Tamil Nadu, for the great trends that they are setting and the great achievements that they are making in this aspect. More eye banks have to be set up with NGO participations to achieve these goals. Hospital Cornea Retrieval program is effective and it needs to be strengthened and encouraged. And every IMA member working in any hospital or owning hospitals should take this up as priority so that patients can be deceased, the relatives can be grief counseled, and cornea retrieval can be increased. Newer technologies and techniques are going to yield better outcomes, and it needs to be.
Thank you.
Thank you, Dr. Shibu Varghese. It was a very nice presentation. You made it simple, but also you went into the depth and you covered even the future trends, and you shared one of the experience, like real-time beneficiaries feedback. That was excellent. It's a real motivator for all of us to promote eye donation in our day-to-day life and clinical practice wherever that is possible. So questions in the end. We'll go to the next talk. It will be from none other than Dr. V.R. Ravi. Ravi sir, I know him for the past 2 years. So Dr. V.R. Ravi, he's a senior most orthopedician. More than orthopedician, I remember whenever I hear about Ravi sir is his work in regenerative medicine. Like he has been working this for the past 10 years, more than 10 years actually. So he has his own lab. It was always nice to sit and discuss with him regarding the present role of stem cells in various specialties, not only in orthopedics. If you ask him what is the role of stem cells in oncology, he will give lecture for hours. So much work he has done. He is a pioneer in that particular field, and he's a course director for IMA Regenerative Medicine. So he did his MBBS from Tanjore Medical College and MS from Madras Medical College. And we are just waiting to hear from you, sir, regarding the stem cell donation. Thank you. Over to Dr. Ravi, sir.
Thank you, Dr. Arun, for the nice words. Actually, it is really a challenge to talk after the talk of an ophthalmologist, particularly like Dr. Shibu. So ophthalmologists, they are always futuristic. As you said, what we think is going to be in the future, they have already done. So like Dr. Abul said, when the demand is more, what are we going to do? So they already split the cornea and then made it into layers. And then they were able to give it to more people. Then after splitting the cornea, now they have split it into cells. So they have split into stem cells, limbal stem cells. Now we are hearing about trabecular meshwork stem cells and retinal pigment epithelium stem cells. So I always take the ophthalmologist as my guide. So this talk on stem cell donation is actually, we will be compiling not only the bone marrow transplant, which is the most popular stem cell donation, but the other aspects of stem cell also. Next slide. So next slide, Avinash. Hello. Yeah. So actually, I just started off showing a small awareness video on organ donation. So this is showing the kind heart of a child, the innocent child willing to donate its organs for a waiting donor. Is the audio available?
No, sir, audio is not going.
Okay. So this child is a cancer patient who is going for therapy, and she is willing to donate her organs when she sees that another man needs the organ. Though her father is very reluctant, the child is very bold, and she says that God loves everybody. So I also love this man, and I would give my organ to this man who needs the organ. So this is actually a very touching video. So we're coming to the definition of stem cell. A stem cell can renew itself. It can also differentiate into any type of cell. A stem cell can become a heart cell, it can become a liver cell or a kidney cell or any cell type. So the stem cell can do both, either self-renew or it can differentiate into different cell types. Next slide. So there are different types of stem cells, and who can be the donors for stem cells. The newborn can be a donor because it has got the umbilical stem cells. So the umbilical cord stem cells as well as the umbilical cord tissue also has got the Wharton's jelly is a good source for stem cells. Mothers, pregnant mothers can be stem cell donors. Yeah, their placenta, their amniotic membrane, amniotic fluid contain a lot of stem cells, and they are also a potential source for donation of the stem cells. Any adult male and female healthy male or female from the bone marrow, from fat and other organs, can donate the stem cells. Next slide. Most of us know that there are two types of stem cells. One is the hematopoietic stem cells and the other is the non-hematopoietic stem cells. Usually hematopoietic stem cells save the lives. Patients have suffering from leukemia, lymphoma and other blood dyscrasias. So when they are suffering and when it becomes lethal, when they undergo chemotherapy, radiotherapy and their bone marrow is suppressed, then the hematopoietic stem cells are transplanted. It was previously called as, it is even now popularly called as bone marrow transplant. There is another non-hematopoietic stem cells which are seen in the bone marrow and the other tissues of the organ of the body, and they can also be used as donors. So we will see how it is done. Next slide. So as I said, for lethal diseases like leukemia, lymphoma, and blood dyscrasias like thalassemia, sickle cell anemia, the bone marrow transplant is done, where the hematopoietic stem cells, the stem cells which can become an RBC or a WBC or a platelet, so these cells are used to repopulate the bone marrow. Whereas the non-hematopoietic stem cells currently which are used are for the osteoarthritis knee, for the diabetic ulcer, for the Burgess disease, hair and skin regeneration. Graft versus host disease is the very recent indication which was approved by the USA FDA for the mesenchymal stem cell therapy. So there are a lot of non-lethal chronic diseases which are becoming popular. All of us know that the hematopoietic stem cells are widely popular, but recently the non-hematopoietic stem cells are becoming popular because we are trying to understand how we can utilize these stem cells. Next slide. So donors for stem cells, as I said, the adult, we can be a donor, you can be a donor, or the child can be a donor. Adult tissues, the peripheral blood is usually nowadays taken for hematopoietic stem cells. Previously for blood dyscrasias and leukemia, lymphoma, they were using the bone marrow. So they were taking the stem cells by puncturing the bone marrow and aspirating it. But nowadays, after they got very good drugs, which can mobilize the stem cells from the bone marrow to the peripheral blood, nowadays, mostly it is done from the peripheral blood. Though it is called as bone marrow transplant, it is done taken from the peripheral blood after mobilization, and then it is administered into the peripheral blood so that it gets homed into the bone marrow. Bone marrow as itself can also be taken as a source, and it is also done in selected cases. And the umbilical cord and the cord blood as well as the Wharton's jelly, which contains a huge population of mesenchymal stem cells. All of us know that today the cord blood banks are very popular, and a lot of people have stored the cord blood of their children for the child's own use. And there are public cord blood banks where a child's cord blood can be stored for others' use also. It is a public storage where the parents do not pay for the storage, but in case if they want, they have to pay and get the stem cells. Next slide. So a lot of awareness has to happen in this field, because as Dr. Abul said, the donors, the need for the donors is going to be great, and we have to match the demand. There are a lot of famous persons like Bollywood actor Salman Khan donated. Kanmani Kannan from Pachapirmalpatti. She is from Trichy district, Pachapirmalpatti, and as a medical student in Kerala, she donated a stem cell for a thalassemia child. So similarly, there are a lot of we come to know through social media and other media that this awareness is definitely increasing, and we should contribute to the cause, as Dr. Rajesh Babu has said, and keep Tamil Nadu in the top of the list. Next slide. And who to approach if you want to donate stem cells. Suppose you want to donate the stem cells. If you want to donate your own stem cells for bone marrow transplant, there are organizations like Datri at Chennai, and then MDRI at Mumbai, and the ISBMT at Bengaluru. So I have you can click this slide because I have given the phone numbers of these institutes. So whoever wants to contact Datri or MDRI or ISBMT can do so. Similarly, if your child's umbilical cord stem cells also, if you want to store in a private cord blood storage units like LifeCell, Cord Life, and CryoVault, and there are public cord blood storage like Reliance and G1 Blood Bank. So in this series of talks, three of us are qualified to talk about these stem cells. Dr. Arun Seshachalam himself is doing bone marrow transplant, and Dr. Prabhakar from Uyirtuli. So he is doing a lot of stem cell transplants, bone marrow transplant, and he was in G1 Blood Bank for 2 years, and I think he will throw some light on that. Next slide, please. And how adults can donate stem cells. In less than 5 minutes, you will know how the stem cell donation is done. This is taken from the Datri's website. So you have to go to their website, check your eligibility, and then follow the screen one by one, which will take you to the personal verification, and then declaration of consent, and finally the donor engagement team will contact the person once they got the address and the phone number, and then they will send a swab. They will send a kit which contains the swab covers, instruction sheet, as well as a postal cover. And once you receive that, you fill up the form in that what you received. And then once you fill up the form, you have to wash your mouth and then take the 2 swabs, put the swab on one side and take from one side of the cheek, and then the other swab other side of the cheek, and then pack it and post it to the Datri. So this can be done from home. So this stem cell, once they take the stem cells from your mouth, they screen those stem cells, and then they take the HLA typing of that and store it in a cloud storage. Once it is stored, any person who raises a demand anywhere in the world, if their HLA details are available, next, Avinash. So if their HLA details are available, it will be matched, and they can be, the patient who is demanding can be a leukemia patient, he can be a lymphoma patient, or a myeloma, sickle cell anemia, thalassemia, immune deficiency syndromes, patients with aplastic anemia. So these are all some of the indications and some of the patients who will be needing those matched stem cells. And since the matching is very rare, it is very rare to get a perfect match. So nowadays they are doing haploidentical matching from the close relatives also. So these are more than 75 diseases are eligible to get this hematopoietic stem cell transplant. Next slide. And once the swab is collected, as I said, the HLA is mapped, and then the HLA, as you know, it has got class 1 and class 2 genes, and then they are matched. There can be a perfect match, but as I said, it is very, very rare to get that. Next slide, Avinash. So once, even if it is not a 10 by 10 match, even a 9 by 10 match is taken, and in cases where you don't get a perfect match, that is when they go for umbilical cord blood stem cells, because umbilical cord stems, because they are naive and they need not have a perfect match. But the problem is the number of cells available in the umbilical cord blood is minimum, and so you will need minimum 2 or 3 units of umbilical cord to give for one adult. Next slide. So if you are found to be a match, then they verify your records, and then the master health checkup is done for the donor, and once the donation can be done, as already said, through the peripheral blood or through a bone marrow donation. So peripheral blood donation, next slide, they will give an injection for 5 days. The granulocyte colony stimulating factor injection for 5 days, it is given to mobilize the stem cells from the bone marrow. It will come to the peripheral blood. Then within 3 to 4 days, you have to bring the patient to a blood bank where there is an apheresis machine. And then once the apheresis machine is put to that machine, his stem cells are retrieved within 3 to 4 hours. The number of cells which are needed, which are already calculated, more than the number needed, is taken from the patient. After screening him, after doing all this physical examination, other screening. And as I said, after giving the GCSF and apheresis, you get the bag containing the stem cells, which is marked with the CD34 marker, which is for the hematopoietic stem cells. Next slide. So bone marrow donation, again, as I said, based on the patient's disorder, nowadays they are not doing much of the bone marrow transplant. The only advantage is there is no need to give the GCSF if you are going to take it straight from the bone marrow. But only problem is it has to be done under anesthesia, because the donor has to be under anesthesia so that we can comfortably take the stem cells from his bone marrow. We have to puncture the bone marrow with a Cook's needle, so it will be painful. So he has to be under anesthesia. But once we take it from the bone marrow, we get a very good number of mononuclear cells. Previously, they were injecting only the mononuclear cells. Nowadays, they are separating the hematopoietic stem cells. And recently in USA, the hematopoietic stem cells taken from one unit was divided into 2 halves, and 1 half was cultured so that the number was increased. So, and what are the steps if you want to donate the cord blood of your child? Once the baby is born, the cord is clamped and the cord blood is collected, and it is delivered to the cord blood bank. And once they receive it, they process it, and then using some Sepax machine, they separate the stem cells and store it in a liquid nitrogen tank. And once a match is requested, it is given for the suffering patients. Next slide. So cord blood stem cells again can be autologous or allogenic. If the donor himself is the recipient, it is autologous. Stem cells are taken at birth, but when the same child develops a problem later in life, like a leukemia or lymphoma, so the autologous stem cells can be used. Donor is different from recipient in allogenic stem cell transplants, where the stem cells are used for adults with leukemia or lymphoma. And as I said, because the umbilical cord contains less number of stem cells, 2 or more cord blood units will be needed because of the difference in the body weight. Next slide. And who will be the recipient patients for MSC? We already saw who are all the patients who will need for HSC, like leukemia, lymphoma, and other diseases. Who will be the recipient patients for MSC? Osteoarthritis patients, the thromboangiitis obliterans, diabetic ulcer, corneal blindness. As Dr. Shibu said, the limbal stem cells can be used for corneal blindness. GVHD, as I said recently, US FDA has approved allogenic bone marrow derived stem cells for pediatric steroid resistant GVHD. Similarly, China also gave a recent approval for the same indication. Crohn's disease with recurrent fistula in ano. More than 15 diseases are already approved for MSC, that is mesenchymal stem cell therapy. Next slide. India is one of the top countries. In fact, India is the top country in the number of indications which are approved for stem cell therapy. So this is one product where it is approved for the osteoarthritis as well as the critical limb ischemia, diabetic ulcers. I have shown this slide only to show that the bone marrow is taken from a donor, young donor, the screened donor. His bone marrow is taken from his posterior iliac crest. It is taken from 3 people and then it is pooled, and from what is got from 3 people can be multiplied into 3,000 doses or even 1 million doses by using culture method. And once we culture these stem cells, they are tested, and then all the clinical trials are done for osteoarthritis, critical limb ischemia, and these products have come to the market. And as I said, in India, we have 7 different products which are used in more than 10 diseases, including osteoarthritis, which is my specialty. Next slide. So coming to the end of the talk, Tamil Nadu, as I said, is the leader of the organ transplant. We need not repeat it every time, but already we are the top because 12,253 organs have been donated. You can see the wide variety of organs which have been taken and used in different patients. We were only thinking of the heart, lung, kidney, and other cornea and other things, but hand and then bone, skin, and many other organs are also used. There you can see the demand is also there for a significant number of these organs. Next slide. So the Transplant is maintaining the waiting list. So here you can see the waiting list for all these organs, and by utilizing research techniques, newer techniques like splitting the cornea, we can see how we can use these stem cells to match this demand. Next slide. So Tamil Nadu is also a role model in maximum organ utilization. So in every aspect of organ donation, Tamil Nadu is the role model. Next slide. Next slide. So it just shows the sincerity of the team, the IMA team, as well as all the doctors in the government sector and the private sector who work together to achieve this. Before ending, I would like to just show that this football player from Tamil Nadu, a young teenage girl, when she was injured, her ligament was badly torn. Her cruciate ligament was torn. Her father himself was a donor. So he donated his ligament, and this was done at Chennai in Omandur Hospital in 2022. I just wanted to show this to show that not only heart, lungs, kidney, eye, even things like ligaments and other tissues are now possible to be transplanted, and we should always be on the lookout for ways to help people. And thanks to Dr. Rajesh Babu sir for organizing this and spreading the awareness. Thank you. So this is a camp which we conducted in Dhanalakshmi Srinivasan Medical College, and as well as in the Tamil Nadu Orthopedic Association. As Dr. Rajesh Babu said, we have to be more cohesive in organizing such camps. Here, the swab is being taken and the donor card is being given. Next slide. So thank you, sir.
Thank you, Dr. Ravi sir. It was a splendid presentation. Actually, it is nice to see all the work what you have done, and not only in the field of orthopedics, but also in all other fields. So please continue your good work and show us more light on this particular subject. And yes, as you said, it's not only transplant does not mean only eye donation and liver and kidney. Probably a lot of other organs can be done. Only thing is probably the learning curve, the expertise, the donors, all these things need to be there. Probably all these things are a matter of time. Probably more data is going to come and more people are going to benefit it. Thank you. With that, we'll go to the next lecture. That will be the last one by Dr. Prabhakaran. So, sir, can you... Dr. Prabhakaran, sir, you are there?
Yes, sir, I'm here.
Okay. So Dr. Prabhakaran, he's MD in transfusion medicine. To be honest, I know Prabhakaran for the past 5 years because the moment when we thought we will start the bone marrow transplant unit in our center, the one name that came to all of us as far as the bone marrow stem cell harvest is Dr. Prabhakaran. So he has been involved in stem cell harvesting and stem cell transfusion in many of the centers in and around Trichy and Namakkal. Actually, he was one of the main person in the team, in the transplant team, and I'm very happy to introduce him. He's a son of Trichy. He's a son of the soil. So he is from Teppakulam Bishop Heber Higher Secondary School, and he did his MBBS from Thuthukudi Government School, Government Medical College, and MD in transfusion medicine in PGH Chandigarh. Then after that, he worked for a while in G1 Blood Bank, and then he started his own unit, blood bank unit in Trichy. Now he runs a unit. He helps bone marrow transplantation in multiple centers, including our center, which is Dr. GVN Cancer Institute. So with this very humble person, lot of knowledge, definitely the next half an hour we will gain into the stem cell transplantation and bone marrow transplantation. Over to Dr. Prabhakaran.
Thank you, sir. Sir, thank you, sir. Thank you, Ravi, sir, and thank you, Dr. Avinash Gandhi, for helping me to give this presentation. And I thank IMA TNSB and Organ Donation Committee. So, coming to the journey of blood. Sir, next slide, sir. So,
can you see, sir?
Yes, sir. Yes, sir. So the estimated blood requirement is 1% of our population, sir. So yearly requirement, it's 1.4 crore units. And the last reported collection is around 1 crore units. And we are having shortfall of nearly 40 lakh units. But the eligible population to donate blood is around 60%. So they are coming forward for blood donation. Thank you. Next slide. So why blood donation is so important is there is no substitute for blood. So till now we are unable to grow blood in our labs. So till 30% of blood loss we can manage with crystalloids and colloids. Next slide, please. So after 30% loss, we have to give red cell transfusion. Otherwise, the patient might go for hypoxic changes. Next slide. So the main reason why blood donation is so important is because of these cells, red cells, platelets, and blood contains clotting factors and plasma proteins. So when you donate blood, we separate all these into components and give. The only part, WBC, this WBC is the unwanted component in blood, because WBC, it will act in a self-defense mode. So when it enters a patient, it will cause reactions to the patients. Next slide. So we will brush a little bit history. So William Harvey discovered the blood circulation in 16th century. Next slide. So blood donation மூலமா we can save lives. So lives can be saved in animal transfusion. Next slide by Richard Lower. Next slide. So initial days, they believed that animal blood is purer than human blood. So they started transfusing sheep's blood, goat's blood, then pig's blood, everything. And people started dying. Then they realized that we should start transfusing from a human. And first human to human transfusion was done in the 18th century. Out of the 10 transfusions done by Dr. James Blundell, 5 patients survived and 5 of them died. So again, there was pressure from the government as well as a church to stop blood transfusion. Next slide. So only after a blood group discovery, all the transfusion became safer. And the main person behind this is Karl Landsteiner. Next slide. So he discovered the ABO blood groups. So his birthday on June 14th is celebrated as World Blood Donors Day. And ABO is one of the blood group systems. So till now, there are more than 43 blood group systems has been identified. ABO is one blood group system, RH is one blood group system, likewise Bombay, Kell, Kidd, Duffy, and there is a blood group system called Indian blood group. So like that, there are 43 blood group systems are there based on the antigens present on the red cell surface. Next slide. So earlier days of transfusion, they transfused like this only. They used to collect blood in a glass bottles and they transfuse it to the patients. In this, there is lots of adverse reactions used to happen in this. Gas embolism used to occur. Next slide. So mainly glass bottles were used first in the Spanish Civil War. So Spanish War was a major thing in improvement of transfusion services. So World War I and World War II contributed to the major inventions in blood banking. And nowadays we are using plastic bags for collecting blood. In this way, we can transport blood easier and we can keep the blood sterile. Next slide. So these are the various components we can collect from whole blood. So when you go to blood bank for blood donation, at the max we can initially we used to collect it as whole blood and we used to give it to the patient. But after advancement, we used to separate it into components. Now our blood bank is 100% component blood bank, where we prepare packed red blood cell, fresh frozen plasma and platelet concentrate usually. And when there is a requirement for cryoprecipitate, we prepare cryoprecipitate from fresh frozen plasma. And we can use that after separating cryoprecipitate, the remaining plasma also can be used as cryopore plasma. Next slide. So when we prepare packed cells, we usually store it at 2 to 6 degrees Celsius for maximum up to 42 days. If we collect packed cell and store it in CPDA solution, we can store it for 35 days. And if we store it in additive solution, like SAGM solutions are there, where we add mannitol. So the mannitol will help to maintain the red cell membrane surface integrity. So where we can store it for up to 42 days and we can use it. Next slide. So fresh frozen plasma, fresh frozen plasma should be collected from a whole blood, prepared from a whole blood and stored within 8 hours from the time of donation. And it's cooled down to more than, to less than minus 20 degrees centigrade. And you can store it up to maximum of 1 year and you can use it. And even after 1 year, we usually don't discard. By the end of their life cycle, we usually give it for fractionation. And where they prepare albumin, this PCC and fibrinogen, everything are prepared from this component. Next slide. And platelets, the life we store it for maximum of 5 days at 20 to 24 degree Celsius temperature. And platelets, we usually keep it in a platelet agitator. Platelet should be kept in a constantly agitation. Otherwise, once the platelet settles, it will degranulate and it will lose its character. So it should be kept in constant agitation. Next slide. So India's first blood bank was established in 1942. During the World War time only, they started blood bank in India. The first blood bank was established in Calcutta. Next slide. And all blood and blood components are classified as drug, and it comes under Drugs and Cosmetic Act. And initially, it was paid donation was there in India, but due to the transmission of many transfusion infections, they banned professional blood donation in 1998. It was banned by the Supreme Court, and only voluntary, non-remunerated blood donors are allowed to donate blood. Next slide. This is mainly due to the effort of the single person, J.G. Jolly. He was a professor in PGI Chandigarh. So he took the initiative to abolish this paid donation and encourage voluntary blood donation. And his birthday comes on October 1st, which is celebrated as National Voluntary Blood Donation Day. Desiya Tannarva Rattadana Nal. So we used to celebrate his birthday. Next slide. So why we ask the donors to donate regularly? So I studied in PGI Chandigarh. So அங்க வந்து பாத்தீங்கன்னா டோனர் வந்து we used to ask them not to donate because 18 வயசு முடிஞ்ச உடனே they come for donation because the Sikh people அவங்க வந்து பாத்தீங்கன்னா வந்து they regularly donate blood. சீக்கியர்னாலே வந்து எல்லா விதமான தானமும் பண்றவங்க தான் அப்படின்ற மாதிரி they have that அவங்களோட மத கொள்கை அந்த மாதிரி இருக்கு. ஸோ அதனால வந்து பாத்தீங்கன்னா 18th பர்த்டே கம்ப்ளீட் ஆன உடனே அவங்க வந்து செலிப்ரேட் பண்றதே பிளட் பேங்க்ல தான் செலிப்ரேட் பண்ணுவாங்க. ஸோ we used to collect around 1 lakh units per year. So our blood bank was the largest by volume of collection in Southeast Asia. ஸோ அங்கே வந்து டொனேட் பண்ண வந்தாங்கன்னா வேணாம்னு சொல்லுவாங்க. ஆனால் அங்கே வந்து ஃபோர்ஸ் பண்ணி இல்லை நாங்கள் கண்டிப்பாக கொடுத்தே தீர்வோன்னு கொடுப்பாங்க. பட் ஆஃப்டர் கேம் டு தமிழ்நாடு இட் வாஸ் ரிவர்ஸ். ஸோ இங்கே வந்து பீப்புள் வந்து அந்த அளவுக்கு அவேர்னஸ் இல்லை. ஈவன் இஃப் பீப்புள் ஆர் வில்லிங் டு டொனேட், இப்போ காலேஜஸ் போனோம்னா கேம்ப் பண்ணுறோன்னா அவேர்னஸ் கொடுக்குறோம், ஸ்டூடெண்ட்ஸ் ஆர் வில்லிங் டு டொனேட். பட் காலேஜஸில் வந்து என்னென்னா ஸ்டூடெண்ட் டொனேட் பண்ணும்போது மயக்கம் போட்டோன்னா பேரண்ட்ஸ்க்கு யார் பதில் சொல்கிறது? அண்ட் பேரண்ட்ஸ் கிட்ட கன்சென்ட் வாங்கிட்டோம்னா கன்சென்ட் ஃபார்ம் கொடுத்தோம்னா பேரண்ட்ஸ் வந்து இல்லை என் பையன் படிச்சுட்டு இருக்க பையன் அவனே வீக்காக தான் இருக்கான் அப்படின்னு சொல்லிட்டு they are not allowing to donate. So here we are collecting around 4 to 5,000 units annually. ஸோ அப்படியே ஒர்க் லோட் வந்து கிட்டத்தட்ட half a month கலெக்ஷன் தான் இங்கே 1 year ஃபுல்லாக பண்ணுறோம். ஸோ அந்தளவுக்கு தான் அவேர்னஸ் இருக்குது. அண்ட் பீப்புள் ஆர் ஆஃப் த தாட் தட் பிளட் வேணும்னா டொனேட் பண்ணலாம். ஸோ பீப்புள் யாரை பிளட் பேங்க்லேருந்து ஃபோன் பண்ணால் இல்லை அட்டண்டர்ஸ் கால் பண்ணால் வில் டொனேட். பிளட் பேங்க்லேருந்து ஃபோன் பண்ணால் கூட வந்து இவங்க ஸ்டாக் வைக்கிறதுக்காண்டி தான் வந்து கூப்பிடுறாங்க. அட்டண்டர்ஸ் கால் பண்ணால் டொனேட் பண்ணுவோம். இல்லை ட்ரீட் பண்ண டாக்டரே வந்து அதை பற்றி சொல்லவே இல்லை, டொனேட் பண்ணுங்கன்னு சொல்லலை, நாங்கள் ஏன் டொனேட் பண்ணோம், தே வில் கம் அண்ட் ஆர்கியூ இன் அவர் பிளட் பேங்க். நெக்ஸ்ட் லைன். So the main reason we ask them to donate regularly every 3 months, whether you receive call from blood bank or not, you donate in the nearest blood bank. எதனால சொல்றோம்னா, when you donate blood, it takes minimum 3 to 4.5 hours for us to completely test and separate it into components and give it to the patients. So in case of accidents or in emergencies, patient might have already lost blood, and the golden timeline, if you don't transfuse, we might lose the patient. So that's the reason mainly we ask them to donate blood regularly. Next slide. So mainly donor selection criteria வந்து பாத்தீங்கன்னா வந்து who all can donate, whoever is above 18 years and up to 65 years they can donate. And body weight more than 45 kg they are eligible for donation. There is no upper limit for weight. And hemoglobin more than 12.5 gram per deciliter they can donate. And these are the few questions they usually ask. நான் டயபெட்டிக்காக இருக்கேன், நான் ஹைப்பர்டென்சிவ், நான் டொனேட் பண்ணக்கூடாது அப்படின்னு எங்கள் டாக்டர் சொல்லியிருக்காங்க. பட் diabetics on oral hypoglycemic under good control they can donate. And hypertensive, if the systolic BP is between 100 and 140, and if the diastolic BP is between 60 and 90, and if they are on drugs, they still can donate blood. Next slide. So who cannot donate blood? Permanent deferral வந்து பாத்தீங்கன்னா drug abuse history இருக்கிறவங்க, cancer survivors, and cardiac problems, and donor with infection like HIV, hepatitis B, hepatitis C, syphilis are all permanently deferral. Next slide. So there are a few questions among the donors. Do I get the infection by donating blood? Because they have the fear. Blood donate பண்ணோம்னா எனக்கு இன்ஃபெக்ஷன் வந்துரும்னு. So we used to tell them we use only single use needles which are sterile, and once used it's destroyed completely. And when can one donate? So recently January month they have issued a new guidelines from our Ministry of Health and Welfare. They have given new guidelines for all men can donate every 3 months and women can donate every 4 months. Next slide. And this is also a regular question which we get in the college setup. They say, I have low HP. What are the ways to improve our HP? We recommend them only if the physical activity is increased, there is a need for increase in HP. So we ask them to undergo regular physical activity and consume food rich in iron, and regular deworming will help to improve the hemoglobin. And in new guidelines also, actually I was unable to share that. So in new guidelines, there are a lot of changes now. Previously, if we ask the question, if you had consumed alcohol, they should not donate for more than 24 hours. But the new guidelines suggest that if they are not under the influence of alcohol, they can donate. Then previously for tattoo, ear piercing, everything, the deferral period was only 6 months. Now it's 12 months. It's nearly 1 year. If they have tattooing or ear piercing, they cannot donate for 1 year. So these are the recent changes which came. And previously, if you are taking thyroxine tablets, you cannot donate. So if you are hypothyroid, you can't donate. But now they have revised the guidelines. If you are hypothyroid and on medication, you can donate. If you are a hyperthyroid patient, thyrotoxicosis, you can't donate. Permanently, you can't donate. And rest all endocrine disorders, it's permanent deferral. Next slide. So female donors, they should not donate if they are pregnant or breastfeeding, and if they got abortion in the last 6 months, and if they are on treatment for infertility. And newer guidelines suggest that if they are on menstruation during that menstrual cycle, they should not donate. But all the Western countries, they encourage blood donation during menstruation because it helps psychologically for the female. But here the guidelines are not yet changed. And if you had any history of blood transfusion, you should not donate for 1 year. Blood transfusion or immunoglobulins. For example, rabies vaccination, hepatitis B immunoglobulin, if you are taken, you should not donate for 1 year. Next slide. So how many lives we can save? So maximum, if you start donating by 18 until 65 years, maximum you can donate 180 times. And each time when you donate, we can separate your blood into 4 components and give it to 4 different people. So you can save around 750% in your life. So this is what we used to tell to the donors and motivate them to donate blood, because you are saving not 750%, you are saving 750 families. Next slide. So நிறைய பேர் கேட்குற கேள்விதான், even if I donate while collecting blood is charged. Why? Because the blood banks are run by charitable trust, which is run on a not-for-profit. It is a not-for-profit organization. They have to cover the basic expenses like blood bags, staff salary, EB, everything, for which government has given a guideline how much you can recover. Next slide. So if you are giving it as a whole blood, in government hospital, they can charge up to 1,050, and private hospital, they can charge up to 1,450 rupees. Next slide. And if you are giving it as components, we can charge up to 2,250 rupees. And for additional tests, there is additional price limit. For example, if you are giving leukodepleted with inline filter bags, you can charge additionally 1,000 rupees for that. So like that, our Tamil Nadu government is giving blood free of charges. Medical treatment is free of charges in GH. So they will not be paying this. So, but in private blood banks, they used to charge this. Next slide. So pre-donation, what should be done and what should not be done. So mainly what we have observed is, before just 10 minutes before donating, if they consume 350 to 350 ml or around a half liter of water, the post-donation vasovagal syncope, that percentage is significantly reduced. We have done this a study in PGI and we have published a paper. So we recommend donors to just have a glass of water before donating. Just before donating, they should have a glass of water so that the blood loss, volume loss will be replaced immediately. And they should not donate on empty stomach, and they should have a sufficient sound sleep before donating. and they should read a handout which we provide, because we usually provide a self-deferral form. The donor can self-defer them, and if they are not willing to donate, they can leave. Like that we have prepared and we are used to give them, and they should not hide any illness from the medical officer who is examining. Next slide. And post donation, we ask them to rest at least for 10 to 15 minutes before getting up, because usually when they get up, due to the effect of gravity, the blood flow to the brain will be decreased, so they will feel the drowsiness. So after donation, usually in colleges, when they donate, due to peer pressure, after donation they usually stand up and run away, and after 1 or 2 minutes they will just faint and fall down, and they will have some injury. So we usually recommend after donation they should lie for 10 to 15 minutes, have adequate rest, make the body realize that it has lost blood, and give time for adjustment. And we ask them to drink more fluids for the 24 hours and not to carry any heavy weights or do any gym or workout or any sports activities for next 24 hours. Next slide. So safe blood starts with me. So thank you for the opportunity. And I have one more presentation about the myths and facts of blood component transfusion. If time permits and if the moderator allows, I can present, otherwise no issues. Thank you.
Mostly that will come in the question and answer.
So
People
what we
start
will do is next month we will include you in that talk, and that time you can have the talk, sir.
Sure, sir. Sure, sir.
Before going for the discussion, I wanted to introduce one of the persons who has donated his father's body for the body donation. I invite Saravanan. Saravanan, are you there? Saravanan?
Yes, sir. Yes, sir. I am.
You show your face also, no? Video click on
Yes, sir.
This is Mr. Saravanan, who has donated his father's body to the Teni Medical College. Actually, that has not been registered before, but he went to this anatomy department. I like to thank him for donating the body, and I invite him to give his experience, how he did the procedure. Just I wanted to get his ideas about it. Taranan, நீங்க என்ன நடந்ததுன்னு சொல்லுங்க.
ஓகே சார், சரி
சொல்லுங்க.
ஓகே சார். எங்க ஃபாதருடைய ஃபைனல் ஆசை வந்து என்னன்னா, ஒரு பாடியை வந்து மெடிக்கல் காலேஜுக்கு டொனேட் பண்ணணும், அடுத்து கண்களை வந்து தானம் பண்ணணுங்கிறது வந்து அவருடைய ஆசை. பட் நாங்கள் ரிஜிஸ்டர் பண்ணலை. 19th நைட் வந்து 11:35 வந்து அவர் பாஸ்டவே. அந்த டயத்தில் என்னால் ஒன்றும் பண்ண முடியாது. நான் கிளம்பி ஊருக்கு போயிட்டு இருக்கிறப்ப வந்து ஃபர்ஸ்ட் தேனி அரவிந்த் ஹாஸ்பிட்டலுக்கு ஃபோன் பண்ணி இந்த மாதிரி வந்து ஃபாதர் இறந்துட்டாரு, டொனேட் பண்ணணும்னு சொல்லி அவர் சொல்லியிருக்காரு, அதனால வந்து நீங்க வந்து கோஆர்டினேட் பண்ணி பண்ணீங்கன்னா நல்லா இருக்கும்னு சொல்லி ரெக்வஸ்ட் பண்ணேன். இமிடியேட்லி தே அரேஞ்ச்ட் a team and collected both the eyes within 6 hours. And then, but we have not registered the for a body donation, so that I was worried about how I am going to fulfill his final wish. On the way, Rajesh Babu, it came in mind that Rajesh Babu's name. Once I met in Coimbatore, he said he donated his father's eye, skin and body also. That came into mind. Immediately I sent a message to Dr. Rajesh Babu. Sir contacted with their colleagues from Tirunelveli Medical College, and they spoke with Theni Medical College authorities, also anatomy department authorities, and they informed me that go and contact anatomy department. When I went to anatomy department, the professor morning 9 o'clock he came and said that I asked what are the formalities. He said that is now, the earlier it was the tedious formalities, that is you have to get the advocate certificate, all those things. Now the government liberalized the formalities. Only thing is you have to give the form filled, and with death certificate, if death certificate is available. If it is not available, that is fine. And then with the two IDs of all. That is the body who we are donating, and then their dependents. If it is husband, it is wife, and then child, that sons or daughters. Minimum 2%. That is apart from that spouse, minimum 2% is needed. He said bring all the forms filled and along with all the certificates and bring the body. If you want to coordinate us to arrange for ambulance, we will make the arrangement, he said, but we don't know the exact time. So that he said normally 3 o'clock it will close, but you can bring it up to 4 o'clock. We will be waiting. He said at 9 o'clock I contacted the hospital, and then I bought all the application forms and went to my village and filled all the forms with supporting documents, and we brought the body with all our necessary certificates, and then I brought my sisters and my mother also together, and then we filled the form and submitted the body. They very much encouraged us that your father had did a great job. It will forward you in your life, he said. That the department doctor, that is Assistant Professor Rajkumar, and Dr. Relil also they're very kind and did all the arrangements. Due to that, I was able to fulfill my father's final wish. Thank you, sir.
Thank you, Saranan, for your nice gesture, and your father's wish was fulfilled. Thank you for joining us and giving your experience. Let it be an example for all the people here in this among the doctors also. It's a good education for the meeting. So I thank you for joining, and thank you for donating the body. Thank you, Saranan.
Okay, so one additional thing, in my village, around 5 people came and asked me about how we have to donate all those things. It's really I feel very proud that my father did a great job.
That's how we will promote these programs. That is the main thing. Thank you for your gesture. Okay, sir.
Thank you, sir.
Moderator, sir, you can take over. Sir, please unmute yourself.
Thank you, Rajesh Babu, sir. I think that's an excellent gesture. I think we all should follow what one of our IMA member has done. It's a very good, noble gesture. And it's not that he has, like another 5% has come and asked him. And so many of us are going to get inspired, and probably we need to follow the footsteps. So with this, we'll just go to the final leg of this particular program. Any questions to the speakers?
Kidney donation, sir. How about whether our nephrologist is there, Prabhakar, sir? It's not there, I think. Okay. Sir, regarding the eye bank, sir, Subbu Varghese, sir, in Coimbatore, we are planning to create the eye bank. IMA eye bank. We are now propagating the message like that. Already there are a lot of eye banks there in Aravind Eye Hospital, and all the people, Sankarai, all are doing it. But what I thought was, instead of they having it, they are not having in all the places. See, we have around 165 branches. If each of the IMA branch is ready to take up the eye bank thing, then it will, at least what they can do is, instead of, they name it as an eye bank, but you can be a part of the retrieval center. For doing the retrieval center, we need to educate more of the ophthalmologists. That is the main thing.
Yes.
And even non-medical people also we can educate. For example, in one of the places nearby to our place, in Metupalayam, whatever the patient is dying in the medical in this government hospital, immediately one staff nurse used to take the eye and send it to the eye bank. That is what they are doing. Like that, we need to educate more people. For that, we should have an IMA eye bank, or it is called as a retrieval center. We will label it as IMA eye bank, but it is a retrieval center. Like that, you ophthalmologists have to come forward, and in all places you can start in your Tiruchi area also can do it, and like that in all the places you can start doing it. This is a small request from
Certainly,
my
sir.
side, sir.
Certainly.
Because
I
in
will,
Coimbatore we are initiating, like that you can do it in all the places also.
Bill, sir, I will certainly take that. I'll collaborate with my colleagues here. We'll come up with a plan for this, executing this.
Sir, then regarding this HIV and I, because once you are putting in a solution and all those things, this antigenicity and all those things disappears now, sir. What about any study there to prove that patients who had an HIV also, the eye can be used? I'd like
Sir,
to know about your experience.
yeah, sir, as far as HIV is concerned, there are no direct studies because, but there is also this case of septicemia. Patients dying from septicemia is one of the contraindications where in hospitals the eyes are not retrieved. But there are several studies which have been done in which patients with proven sepsis, their corneas were transplanted, and there were no cases of endophthalmitis or any other infection happened because the patient was of septicemia. So this is something that is presently the guideline. So some studies, I think, how to do studies where HIV donors, corneas, we need people who are, voluntarily coming forward to receive such, transplants. Knowingly, they have to receive transplant from the HIV positive patients. It's a very difficult thing ethically to do that. But so far, there are no reported studies where proven HIV corneas have been transplanted.
Yes, sir. Thank you, sir. Then, Ravi, sir, regarding this, the umbilical cord and that stem cell, sir. What I want to know is regarding this umbilical cord, how about it is going on, sir? Nowadays, people are collecting it, and what is your statistics about umbilical cord usages? Umbilical cord blood is being used for some of the stem cell studies. Whether
Yes.
what is the any study you have come across? I want to know.
Sir, actually,
because
yeah.
people are saying when they are pregnant and the thing when delivery, they are telling that we have donated, like that they are telling. But the donated thing, how many people have utilized it? We don't know, because that is the thing. It's a very costly affair to store it.
True, sir. Sir, actually, public, as I said, no, private banking is where it is not given to anybody else. It is only the same child who can receive it. So in such cases, the usage is so minimal. So when they collect thousands of units, they probably use only one or two or a very small number they have used. Dr. Prabhakar, he was in Jeevan Blood Bank. They have tried both public as well as the private cord blood storage. Sir, Dr. Prabhakar, can you answer Dr. Rajesh sir's question?
Yes, sir. Yes, sir. Yes, sir. Actually, now that cord blood stem cell transplant has lost its sheen. Previously, when I worked there in 2014-15, there used to be 10 or 15 cord blood transplants at the time. The main problem is the delayed in transplantation. So once you transplant it, it will take a minimum of 20 to 28 days for the transplant. So by that time, the patient will acquire some infections. So that huge risk is there. So instead of that, allogenic bone marrow, now it's peripheral bone marrow stem cells, it's preferred. It's cost effective. So cord blood bank, yearly we run that cord blood bank. It's a public cord blood bank funded by our Tamil Nadu government. Our yearly expense will come around 3 crores for storing it, where you can donate, but it will go to some other person who is in needing it. And as you said, a single unit might not be sufficient. If the patient weight is above 20 kg, they might be needing at least 2 to 3 units of cord blood. So it's difficult to find a match that much amount. And whatever public they are donating, the collection process, it was not streamlined. So if you receive 10 cord blood bags collected from different hospitals, only 1 or 2 will have sufficient stem cells to store. So that was the major issue. Private is completely different. So they are collecting and storing it in live cell, huge amount they are paying it, but I don't know how they are using it, because once if you are not able to pay, that becomes the property of live cell. So they might use it for some other purpose. Actually, we don't know. So private, I can't comment, but public, it's a huge amount cost is involved and it's difficult. So we closed that cord blood bank. By around 2016, they have closed that cord blood bank.
So at present, how many places
Rajesh
we-
Prabhu, sir.
Yes, sir.
I just want to make this, because a lot of audio viewers are there. See, commonest, see, I'm a pediatrician, I'm a medical oncologist who do transplant. So I get a call most of the times just before the delivery whether we should store the umbilical cord. This is common. All of us are going to get this call, because
Yes,
a lot of marketing is happening, a lot of promotion is happening. My
Okay.
answer is very simple. Okay, so when you store in private blood bank, the chance that your child will be using or will be helped by this whatever you have stored, or your the sibling whatever you have stored, is 1 in 1 lakh. So
Yes,
when I really advise them to store the umbilical is when there is another like sibling who is already having a blood cancer or some other diseases which for which there is an umbilical cord indication is there. That is one. For example, there is a sibling who is having acute leukemia on treatment. Mother is going for the next child delivery. Definitely, that particular pregnant lady, we will advise store that in private, pay for that. It's worth. Otherwise, it's always better we tell donate to the public cord blood so that somebody will be benefited. The chance that when there is no disease running in your family and the other sibling is normal, the chance that this umbilical cord what you have stored will be useful for that kid or the next sibling is 1 in 1 lakh, or it is even more than 1 in 1. So there is not much of cost benefit in that. So it's always better to go for public cord blood bank.
So the public cord blood bank, any available, sir, here in our places?
No, sir. G1 was the only public cord blood bank at that time in Tamil Nadu, but they have stopped collecting cord blood.
We need to create something like that.
No,
Sir, actually,
now the preferred is mainly this unrelated blood donors, stem cell donors, and now the latest trend is haploidentical donors. Father
Yes.
and mother, they can donate for the babies. That's the recent trend.
Sir, haploidentical, yes. The question is, when you give haploidentical, what are the chances of rejection? So when there is more chance for rejection, so what are the other alternates? So regarding this recent approval for GVHD, acute GVHD. Few words, sir.
Sir, actually, I have not gone into that much detail because we are doing only mainly autologous stem cell transplant as well as allogenic matched unrelated donors. So what we say.
Okay.
So haploidentical we are not done, but what the literature say is even if it is 6/10 match and if it is from the mother, the rejection rate is very less. If it is from the father, the rejection is more higher, and if it is from the mother, the rejection rate is much lesser, and complications also much lesser.
Okay, okay, sir. This is just an information that there has been a recent approval by 2 countries, USA and China, for the umbilical cord stem cell from the China as well bone marrow stem cell from USA. They are approved for GVHD, particularly steroid resistant GVHD. The first approval was for the pediatric cases, and then it is now, the next approval will be for the adult cases also. Trials are going on.
Thank you, Ravi sir. I think we are running late by 30 minutes.
Sorry,
Yes,
Rajesh Babu sir.
You can wind up the session.
Okay, so
sir, excuse me, sir. Sir,
yes.
Dr. Subna here. Sir, Dr. Ravi, sir.
Yes, ma'am.
Any side effects or precautions we have to guide for the stem cell donors, sir?
Donor, they do a, once you give the willingness, they do a thorough physical examination and ultrasound. Routine medical examination is done, blood tests are done. So only after confirming the that you are fit, it is being taken. And while donating, when they give the GCSF, when they give the injection, there is a possibility that they are going to give you 4 or 5 doses of subcutaneous injection before they collect the stem cells from the peripheral blood. But giving the GCSF can cause some amount of body pain, and there can be some amount of hepatosplenomegaly. I don't have a personal experience. Probably Dr. Arun Seshachalam might have done, or Dr. Prabhakar might have done cases.
Sir, we have done, sir. We have done cases. So we are given only main what you are told is correct, absolutely correct. They might have some severe body pain, bone pain, and feverish symptoms. That's all. Once they donate, once we start the GCSF injection, within 2-3 days, it completely wanes off, and they're absolutely normal. The only thing is they need to bear for 4 to 6 hours. They need to lie idle on that couch. That's the only thing. Otherwise, there is absolutely not much side effects for GCSF. And once the donation process is completed, whatever stem cells it's mobilized, it's going to die, and it's going to get cleared off from the body.
Thank you. Thank you.
They have to stay in the hospital for a day, sir?
No. Actually, what we have done, we usually do is we give GCSF injection, granulated colony stimulating factor.
Yes, sir.
We give it, we go to their home, and we used to administer it to donors, because 5 days we need to administer.
Okay.
And after 5th day, they need to come for blood counts. Once the blood count is okay, they can start donating on the 5th day.
Okay, sir.
I think due to like already 30 minutes behind schedule, we'll close the session. Thank you all the speakers. I thank Dr. Ravi, Dr. Prabhakaran, Dr. Shakti, Dr. Shibu Varghese for giving a wonderful lecture. I thank Rajesh Babu sir for the whole opportunity and the initiative. I congratulate him for the initiative, and I wish him he reaches the milestone whatever he is planning. Thank you. And as an IMA member and IMA secretary, definitely from all the branches we will extend our full support to you, sir, so that you will reach your the purpose for what you have started, all these things. Thank you one and all. Probably for the next meeting we'll meet. Thank you.
Thank you, sir.
Thank you.
Suguna madam.
Sir, அருண் சாரே எல்லா வேலையும் முடிச்சிட்டாங்க, எல்லாருக்கும் பக்காவா சொல்லிட்டாங்க.
ஓகே,
ரொம்ப தேங்க்ஸ் சார். எங்க ஊர்ல எந்தூசியாஸ்டிக் டீம் ஆஃப் டாக்டர்ஸ் நல்ல பிளாஸ்ட் பண்ணிட்டாங்க சார். எல்லா செஷனும் ரொம்ப யூஸ்ஃபுல்லா இருந்தது அருண் சார். ஏன்னா இங்க வந்து காலேஜஸ்ல எல்லாம் போய் நாங்க ஸ்பீச் கொடுக்கும்போது இப்ப என்ஜிஓஸை கொஞ்சம் ரொம்ப மோட்டிவேட் பண்ணி அவங்களோட மீட்டிங்ஸ்ல பார்ட்டிசிபேட் பண்ணி கேட்கும்போது இந்த கொஸ்டின்ஸ் எல்லாம் வருது சார். ஸோ வி ஷுட் பி மென்டலி ப்ரிப்பேர்ட் இல்லை சார். அப்போ போய் கேட்டுட்டு இருக்க முடியாதுங்கிறதுனால தான் இப்ப வந்து இன்னைக்கு ஸ்டெம் செல் போன வருஷம் ஃபுல்லா மீட்டிங்ஸ் ராஜேஷ் பாபு சார் எங்களை நல்ல மோட்டிவேட் பண்ணி வச்சிருக்காங்க. இன்னைக்கு ஸ்டெம் செல் பத்தி தெரிஞ்சுக்கிட்டது ரொம்ப சந்தோஷமா இருக்கு ரவி சார். இன்னொரு ஏன்னா நீங்க சொல்ற மாதிரி இந்த பெரிஃபரல் பிளட் கலெக்ஷன்ல பண்ணக்கூடியது இன்னைக்கு நானும் தெரிஞ்சுக்கிட்டேன். ஐம் சோ ஹாப்பி அபவுட் இட். ஐ கேன் மோட்டிவேட் மோர் என்ஜிஓஸ். அவங்களாம் ரொம்ப ஈகரா இருக்காங்க இங்க பிளட் டொனேட் பண்றவங்க எல்லாம். ஸோ அதை பத்தி இன்னும் கொஞ்சம் எடுத்து சொல்றதுக்கும் எனக்கு ஈஸியா இருக்கும் சார். தேங்க்யூ வெரி மச் டு ஆல் ஆஃப் யூ சார்.
தேங்க்யூ. தேங்க்யூ. பாய்.
Thank you, sir.
Thank you. Thank you for nice session, sir. Ravi sir.
Thank you,
sir. Very much. Thank you, sir. Thank you so much, sir.
Thank you,
sir.
Many thanks to Rajesh Babu for a beautiful organization of the CME.
Sir, this is Dr. Bharatwaj, sir.
Yes, speaking.
Sir,
Dr. Bharatwaj.
Sir, thank you. Thank you very much for joining us today. Don't miss our session, sir. Rajesh Babu sir used to blast all the sessions. He'll put different ideas.
I will be taking up the program in Odisha itself.
Yeah.
That's why I'm joining the program. Okay.
Okay. We'll be expecting you every month, sir.
Yes. Thank you very much.
Thank you. Thank you very much for joining us, sir.
Thank you.